Yeah. Yes, that's fine. All right, welcome everyone to today's noon meeting. It is one that we in undergrad are always very proud about, to introduce our undergrad students who will be presenting their research. And the reason we are so very proud is because they don't have to do this work, and they chose to, and they persevered through the process, and it has been quite a learning experience, and so it's really wonderful that they're able to complete this research that they started off in fourth year in their health and context rotation. Very big welcome to our students, and congratulations on this work, and also to their supervisor Maria for guiding them through their process, and their site facilitator Christine for setting up their engagements in the Mitchells Plain community. So we really look forward to hearing you and congratulate you on a great work. So over to you, Zoe, Amira, Mihle, and Mihle. Thank you.
Yeah, so hello, welcome to the School of Public Health noon meeting. So this is our wonderful group, Dean, Mihle, Amira, and myself. I'm Zoe. And today we are going to be presenting, as was mentioned, we are going to be presenting a study that we conducted that kind of stemmed off from the work that we did in our health and context block in our fourth year of med school. And the study that we conducted was entitled HPV Knowledge, Beliefs and Vaccination Promotion by School Staff in Cape Town, South Africa. And we were supervised in this endeavor by Dr. Maria Joes, who we are very, very grateful for. So just to give some context, okay, it is working. To give some context, cervical cancer is an incredibly important public health issue. It's the fourth most frequently diagnosed cancer and fourth leading cause of cancer deaths in women globally as of 2017. And there's also, as we know, HPV infection is linked to cervical cancer development. And there's a notable difference in the incidence of HPV infection and cervical cancer between high-income countries that have a very good functional vaccination coverage versus low and middle-income countries that have much poorer access to healthcare, such as South Africa. Cervical cancer in our country is the most common cancer in women aged 15 to 44 years old. And the most recent population-based mortality data, which was only extended up until 2018, showed that the age standardized mortality rate was approximately 14 per 100,000 women, with higher rates in Black women compared to other groups. And until 2018, which is where the literature stops, there was still an annual increase in mortality rates of about 0.9% per year. And there were a shocking 59,190 cervical cancer deaths recorded between 1999 and 2018. So 99, as I mentioned, 99% of all cervical cancer cases are associated with a persistent infection by high-risk HPV vaccines, HPV virus strains, and HPV 16 and 18 are the most the most dangerous. They are responsible for over 70% of cervical cancer cases. And there are incredible vaccines that we have available. So Cervarix is a bivalent vaccine that provides protection from HPV 16 and 18 with 98.2% efficacy. And then there are also other vaccines available, such as Gardasil, which also protects against the low-risk HPV strains. So to combat this problem, South Africa has instituted the HPV vaccination program in schools. It was introduced in 2014 with the hopes of reducing cervical cancer rates. It's offered to all 9-year-old girls attending public schools in South Africa. And the initial uptake of the first dose of the vaccine was very promising, but since then the uptake has decreased. And just to note that the Cervarix vaccine is the one that's used. It protects against 16 and 18, but it was originally offered as a 2-dose regimen, and it's currently, as of last year, it's now offered as a single-dose regimen. So of course, when you are rolling out a vaccination campaign, there are many logistical things that one needs to consider. There's a lot of planning that goes into something like this. You have to coordinate multiple different departments, the health department, the education department, and then the people on the ground, the school principals, the teachers, the children, the parents. From a logistics standpoint, you have to organize the actual schedules, when these things are going to happen, ensure proper storage and handling of the vaccines. You have to educate the staff and, of course, the parents and the children. And then you have to follow up and actually monitor the children for any side effects or adverse reactions. And integral to this whole web of things that needs to happen is the school health nurse. They are amazing people. They are essentially responsible for all the healthcare services in schools. They ensure the physical, mental, and social well-being of their students. They are responsible for many things. They are responsible for all the public health initiatives. So they are the ones who are doing the health promotion. They are also actually implementing all the policies that are filtered down to them from higher up. They are involved in assessments, screenings for vision, hearing, chronic illnesses, developmental disorders, and they're also, as well as all of this, they're also responsible for education, so education of the staff, as well as the children themselves and the parents. And they have huge impacts. So they improve health outcomes, they enhance learning by, if you have healthier students, they're going to be able to learn better and perform better academically. And then, of course, they, in our particular scope of interest, they have the power to increase vaccination rates and, yeah, support vulnerable students. And, oh, hello. Oh, there we go. And as well as the school health nurse, the principals and the teachers themselves also have a very powerful role to play, especially in things like the vaccination campaign. So they are the ones who are also responsible for educating the students, the parents, talking to the parents on the ground, and then even things like ensuring that the distribution and return of consent forms happens smoothly, and then critically addressing parental concerns and misinformation. So they really are key stakeholders. And we, in our reading around this topic, this idea was confirmed for us by a UK study that found that there was the principals in schools in the UK had a significant impact on the success of school-based vaccination campaigns. So, as I mentioned, this whole project stemmed from our health and context block, during which, this was in 4th year, and during that block we were assigned a area of Cape Town, and we had to develop a health promotion strategy and research proposal. Our area was Mitchell's Plain, and we had to do this with stakeholder engagement, and kind of focus on community identified health priorities rather than us coming in and deciding what we would do. It was really a community-led project. And initially, the protocol that we developed was entitled HPV Vaccination in Mitchell's Plain, Evaluating Awareness, Attitudes and Actions. And then subsequent to our finishing the block, we then, when we decided to take the project forward, we collaborated very closely with one of the school nurses in Mitchell's Plain, who really highlighted for us the the role of the school staff in both ensuring the success of, and also in some ways, in some instances, kind of be acting as a barrier to success for the vaccination campaigns. And so we eventually, our revised protocol was then entitled HPV Knowledge, Beliefs and Vaccination Promotion by School Staff in Cape Town, South Africa. I know you're gonna have to take it because my
and then the other half of health in context was we had to do health promotion in the community that we were placed in. Are you okay?
Yeah.
Okay. So what we had then planned was, again, around this topic of HPV vaccination and then also cervical cancer screening, i.e. pap smears. We had an in-person workshop with the community members as well as the health committee, and we sort of focused on female reproductive anatomy and all the things that I've mentioned previously. And then, as you can see on the slide, we had a pamphlet that we distributed electronically, which sort of just summarized all the information that we had reiterated on the in-person session as well. And then as part of these sessions, we had two mornings where we went back into Mitchell's Plain and we collaborated and had discussions with this Mitchell's Plain Health Committee. And after engaging with them, we identified cervical cancer and HPV vaccine hesitancy as key issues. And this was mainly due to limited community knowledge of everything surrounding HPV, cervical cancer and vaccination, and then as well as parental suspicion of the HPV, as parents are obviously the ones that are filling in the consent forms when the school-based vaccination campaign is taking place. So the committee told us that they desired health education on these topics so that they were empowered to then go out into the community and educate others. Which then leads us to the project that we did. So Zoe already told us how we shifted after finishing the health and context block when we were taking it forward. So the aim we then had was to investigate the knowledge and beliefs of school staff in regarding HPV and vaccination in the area that we were placed. We had three main objectives. The first one was to describe the knowledge and beliefs about the HPV and the vaccine that were held by the school principals and the school health representatives working at public schools, to identify potential barriers for promoting this vaccine, and then to demonstrate heterogeneity in the HPV vaccine knowledge and beliefs among the members that we did the research on. Yeah, it's not, it doesn't want to, but anyway. So in terms of our methods, firstly, we had to get approvals from the UCT Health Research Ethics Committee, as well as the Western Cape Department of Education. The questionnaire that we used was based on a Korean paper that was previously validated, and we then just adapted it to South African context and the way that we have the way the school-based vaccination campaign takes place in our country. In terms of the recruitment process, we had several different ways. The first one was this engagement that we had in-person events with the school health representatives and the principals. We also emailed the questionnaire to them. We had our information sent on the school health representative WhatsApp groups, and then we had used RedCap to email to all eligible participants as well. In terms of who could participate, it was any of the school health representatives and principals who were involved in at least one HPV campaign in the post-COVID era. And then, so now moving on to what just over 56% of the people who were eligible to participate. And then in terms of the demographics, majority of our participants were female, and we had quite a low response rate in principals with only 8 responses, as you can see here on the graph that we have. Majority of the schools were World Health Organization promoting schools, and majority of them were also employed at primary schools. And then just over 83% of the participants were employed at non-fee paying schools. And our median age was 51 to 60 years. Next, just looking at some of the results also linked to the demographics. Just over half of the female participants said that they had undergone a pap smear, and 78.2% of the participants reported that neither them or their children had received the HPV vaccine, which sort of makes sense if we look at the median age range and then when the project was launched, as was only launched in 2014. And then approximately 52% of the schools had a staff member that participated in the study. And as we can see, that admin staff had the most experience with HPV campaigns and teachers the least. Interestingly, many of this, across all staff groups, there was reported that they didn't have any training regarding HPV. So 14.5% of teachers, and then as you can see, the other two on the slides had reported that that's the only amount of them that had received formal training of any kind regarding HPV vaccination. And then specifically looking at teachers, just over 60% of them said that they had received no formal training regarding HPV whatsoever. And then Dean will...
All right, so then moving forwards to the knowledge section of the questionnaire, where we wanted to describe knowledge amongst our participants. Illustrated here are the 19 single best answer questions that were proposed to participants. So participants were given the option of answering true or false, where a predetermined correct answer based on the statement is given. And they were also given the option to submit do not know as a response instead, if they were uncertain of a question. Highlighted here is the top first question was the most correctly answered question, and this was regarding the cervical pap screening program offered in the state sector, that most participants got correct at just over 83%. And interestingly, our most poorly answered question from the survey was the purpose of cervical cytology screening and what is detected on a cervical cytology pap exam. So just a bit more about the knowledge scores themselves. We found that overall, or overwhelmingly, there was a low knowledge score amongst participants, where the median score was 7 out of 19, or just over 35%. We noted or found that administrative staff had the highest scores and principal staff had the lowest scores in our participant group. Another area or variable of interest within the knowledge section of our survey was knowledge uncertainty, which was constructed using the do not know responses to the survey for particular questions, where we were interested to observe if there were areas of grouped uncertainty in participants. And we found that in the survey, more than 40% of participants were uncertain about many different categories of HPV information and knowledge. This included facts regarding the disease process, differences between high and low risk infections, the disease recognition itself, as well as management of the disease. Of note were, another area of note was sources of information of our participants. Reassuringly, we found that health professionals were the most cited amongst participants at 67%, and internet came in second place with 55%, and colleagues being a commonly cited source of information as well between participants. Then when it came to the other sections of our questionnaire, which was our health beliefs and intentions section. We very reassuringly found that despite a low knowledge in participants, there was still a good support of the HPV vaccine itself, where 85.5% of participants would recommend the vaccine to their students. We also saw that the support was consistent across staff roles and wasn't limited to a specific group. And we also noted 89.1% of staff support the continuation of school-based vaccination. And 80% of staff expressed a desire to know more about the HPV vaccine, which is reassuring for future intervention. And then another variable of interest was ambivalent attitudes that were noted in our population group, and this is based on the health belief questions posed. So the health belief questions were using a basic Likert scale from disagree to agree with neutral in the middle. And we wanted to highlight ambivalent attitudes in participants that could be key areas for educational intervention in the future to address opinions or beliefs that weren't firm, but ambivalent instead. So we found that there was a high ambivalence among our participants, around 9 to 10-year-old girls receiving sex education. And specifically in the teachers group, we found that 45.2% of teachers agreed with the statement, leaving a substantial proportion remaining neutral at 38%. And similarly, with regards to being proposed the health belief question of 9 to 10-year-olds receiving the HPV vaccine, there was similarly a large ambivalence of around 20%, as illustrated here in figures as well. And then finally, the last health beliefs that were investigated were regarding knowing more about the HPV vaccine. So we found that participants were aware of their knowledge gaps, with only 9.1% of them feeling adequately equipped to guide their students regarding HPV and HPV-related matters. And with our statistical analysis, we found no significant link between the experience in campaigns and knowledge scores, which was significant to us to know that regardless of how long a school health representative or principal has been in their role and involved in the HPV campaign, it does not necessarily translate into direct knowledge about the campaign. And yeah, we also found that the more uncertain about HPV and HPV vaccine facts people were or participants were, the more likely they were to feel unequipped in the first place.
Okay, and then looking at some of the limitations we had during the study. So as already mentioned, we unfortunately had a small sample size, which affected our ability to generalize some of our findings. We also had a poor response rate from our principals, which affected our ability to draw conclusions from that specific group of individuals. And then the way that our questionnaire was structured also meant that we had to be aware of response bias as well. And then in conclusion, so South African school staff share similar knowledge deficits when compared with other global studies, but demonstrate greater willingness to support vaccination campaigns. We also found that there is ambivalence regarding sex education and that the school health representatives did not feel knowledgeable enough about HPV vaccine and the HPV infection to guide the students as well as the parents regarding their decision to take the vaccine. And then in terms of our advocacy message, so we say that HPV vaccine campaigns need to have some educational component as well as some sort of ability to assess knowledge retention. And there needs to be a collaboration between the schools and the health departments in order to encourage campaign success as well. And then some of our recommendations that we had was to have regular workshops for the school staff on HPV as well as the benefits of the vaccination, and then also having some sort of educational material for the staff as well as for the parents, and then encouraging the principals to take some sort of leadership roles in promoting the vaccines, and then also establishing some sort of feedback mechanism or channels for staff to report any challenges that they face during the campaign or any suggestions they have to improve the campaigns. And then looking at some of our learning points. So a key learning point that we had was that the school health representatives, the school nurses play an important role in the primary public health promotion of vaccines and health, and that they operate in a resource limited context, but despite this have found a way to be our public health champions. And then also that investing in strengthening the relationship between school principals and the school health staff will be critical in fostering and then developing more effective primary health service delivery in our community health setting. So we also were, during our time in developing this research, were able to learn how to construct and design a research study, and then also how to engage in health promotion activities, and just being able to convey accessible information to both the community members and our stakeholders. And then I would just like to thank the school health team, the Western Cape Education Department, as well as their participants for their time and input during the process of our research, as well as to thank our supervisor, Dr. Jose, for their guidance and for helping us during this process.
Fantastic. Thank you to the group for an excellent presentation and for really persevering over the past 2 years to get this work done. We know that it hasn't been easy, and we're really very glad that you could do that and inspire other students as well. I see there's some undergrads from the current 4th year class who are online, and that's you really help to inspire them as well as they go through these processes. There is already a hand online, but I just want to ask a quick question. I think I have heard that you were engaging with the community stakeholders to present these results. Can you just tell us a bit about who you presented to and what the response was?
Absolutely. So I presented back in April after completing all of our analysis and write-up to the school health representatives for the teacher and admin staff. We held a session. It was about an hour long. We focused it mostly on health education, that we could then at least identify gaps and areas of limitation from the study, and I chose to structure it around that, but in terms of the health knowledge. We also discussed briefly the findings and what the implications and recommendations were from our side and how it fits into the larger structure as well. But we had about an hour and a half session together for that. And then Mihle had a session with the principal staff just before that as well, if you'd want to share more about that.
Yeah, it was a session with the principal staff, so presented the research to them, and yeah, the response was they were aware that okay, there was like a low response rate in the principals, and some of them were kind of querying what did we have in place to get the principals involved in the study, and we mentioned all that we had in place. And yeah, but it was a concern for them that they didn't have a lot of principals involved in the study versus like the admin staff and the teachers.
Great. It's interesting because I was a registrar when the HPV vaccine was first rolled out, and it's really interesting to see over time how much has changed and improved, and as it's very reassuring to know that. Before we go online, are there any questions from the room? Emma, Prof. then Monde. Yeah.
Okay, thanks very much. It's absolutely outstanding that you did the work. So well done. And I hope that you're going to try and publish it soon. Yeah. Just a question for clarity, were these groups of principals, or was it one school that you were?
So we sampled all four, so there's 48 primary schools in Mitchell's Plain that we identified to be eligible as they offer the vaccine through the school health program, the immunization program. So we recruited all principals in Mitchell's Plain in those public primary schools, and the 8 responses we got was 8 out of 48.
So yes, I'll echo fantastic for that. You mentioned, you spoke about ambivalence of the staff. You didn't ask why, presumably. Sometimes in these kinds of surveys, people will say that something is risky and they will identify a risk in other people. If you ask them about their own children, quite often, would you have your own child vaccinated? You might get the real answer. And I was also interested, you mentioned you worked with the health committee early on with the health promotion. Did you give them any feedback? Did they have any interest in the research results?
Yet to present it back to them.
Yeah.
Send a written report.
We have one written up, but we haven't directly engaged with the health promotion committee directly, but that is definitely something we should do. And
Put some pressure on the school.
absolutely.
And an idea of the reasons for ambivalence?
So, like, I've definitely had quite a few conversations with individuals in the project time. I couldn't speak for an overall opinion, but topics that often came up was there's a lot of rumors and stories that go around. So a lot of them were around like infection and sick, like acutely unwell adverse reaction, to try and use a term. That spreads very quickly. So that was a question that came a lot. People want to sit down and talk about what are the side effects of the vaccine. So I think, again, it comes quite back to a lack of knowledge of what is a side effect, what's an adverse reaction, what isn't, and unrelated.
And I also think there's a lot of, that's why we specifically chose to look at after COVID, because I think from just conversations that we also had with individuals, there's definitely more fear now since the COVID vaccine. So I also think that could have an influence on people's uncertainty around vaccines in general. That sort of then moved from just COVID era into all vaccines as a whole. But yeah.
And I think also the fact that it was very interesting to us that the third most cited knowledge source was the internet. And I think that the internet is just about the most ambivalent piece you can find. So yeah, you can kind of get information that is pro and against and somewhere in between on every topic. And yeah, I think it's a difficult, I think, especially for school staff who come under so much fire from parents, especially. I think if you have any doubt in your mind about the knowledge that you have, I think the easiest thing is to just be like, well, I don't know, I can't, it's your decision, you must.
And on that point, like, we know that there's growing vaccine misinformation, disinformation on social media, especially driven by what's happening in the US at the moment. Did you pick up any of that, or are we fairly still sheltered from all of that?
I would say less so than I was expecting, but definitely some, like people talk about the TikToks they've been seeing and that's going around at the moment, but it didn't come up much. I would say overwhelmingly it was more just direct concern for the safety of the vaccine or like future health behaviors of their children.
And I think it was just very encouraging that people were overall, even though they felt that their knowledge was poor or lacking, they were ultimately in favor of the vaccine. I think we were almost expecting that there would be more, that there would be a lot, more kind of hesitancy or more outright against the vaccine. So it was encouraging. I think we all were very encouraged by the fact that even though people had very poor knowledge, they were very much willing to gain the knowledge that they needed and also then promote the vaccine. Yeah.
Great.
Okay. Just echo everyone, great presentation. So I think just to follow up on the ambivalence, I've got 2 comments. That was a comment and about the bit that you told us about being resistant. And within about 9 to 14-year-olds receiving sex education in the first place. And that just made me think of, why are they ambivalent? Something to actually explore. But then also just like that graph that you showed us about the knowledge, percentage comparisons, right on top, everyone knows they're eligible for a vaccination. Right at the bottom, nobody knows what a vaccination is. And I was just wondering, did you tease that out? Did you address it? Did you?
So we didn't in the research design or at the process, we didn't explore it further than observing it and statistically analyzing it. But it was something that I brought up. I kind of tried to make it my cornerstone of presenting to the staff in our findings presentation to them, and really coming into why we're doing the screening in the first place, because the screening is for prevention, and that is what our vaccination is doing as well. But not understanding why you're even getting the screening test done makes it very difficult to understand why to take a vaccine or to take additional steps to your health-seeking behaviors. So we didn't explore it. People weren't very confident to share their beliefs and opinions in a big room of people while I was presenting to them. So it was mostly a one-sided, me sharing information to them. But I got a lot of feedback at the end where people felt like they really understood a lot more about what was done. And I hope that's at least something that can slowly disseminate, but it is definitely a peak interest to explore further in the community and probably more at large as well.
Great. I think let's move online. Nsiki has her hand up. Nsiki, go ahead.
Yeah, I thought I should show my face in case they have forgotten what I look like. But I wanted to congratulate the student interns. They're no longer first years. But also, I mean, it's beautiful to see how you handle group work. So I really appreciate that. So I have two questions for you. And I mean, I don't know, I may have missed this, but I wanted to know, how did the gender of your participants influence knowledge outcomes? So that's the one question. The second question relates to your sample size. So you did say that you had a very small sample size, but if you're looking at your recruitment strategy, you are focusing only on public schools. Now, if you're looking at UCT, we have a lot of schools in the UCT precinct. Would you consider, I mean, if you were to repeat this study, would you consider including private schools, considering, I mean, the incidence of cervical cancer and the fact that, I mean, if you're looking at the rate, one has to consider the population dimensions. And so it's not saying that one group is particularly affected a lot more than the other. And in fact, increasingly these days, you see a lot of cervical cancer in younger women who are of age bearing. Of course, that may be variable depending on context. But I mean, if you can just respond to those questions, I would be interested to get your feedback. And then lastly, this is now just by the way, to encourage you to keep to this work. I think you should follow this with a qualitative study, because I mean, you have a lot of unanswered questions, and already, you have inserted, that sense of inquiry in our minds. So I think it would be beautiful to see the second stage of your research. Thank you.
Great, thank you, Nsiki. Go for it.
I'm going to answer the question about the gender groups second, and go to the second question first, which is about repeating the study here. I think that it would be valuable to one, just have a larger sample size and hopefully mitigate a bit of non-response bias and things like that. But I think would be a bit tricky to design to make sure that we are following up on the same train of thought conclusions that we have from the first study. Because in the public sector, the school is offering the vaccine through the immunization program. So teachers have to be involved in giving consent forms and given they are in that role and participate in that part of the HPV campaign, whereas in private institutions, it's not offered. So it's still valuable to gain that insight into what the teachers' perspectives are and what they may be sharing with their students. But just in terms of separating that from our analysis of the effect it has on the campaign, I think would be an important thing to consider first.
I think the private sector, the study design would have to be perhaps looking at like parental knowledge rather than
because
staff
it's their
knowledge.
prerogative to
Yeah.
get their children vaccinated.
Yeah, or to
Yeah.
but the school staff.
Then offered.
Yeah.
Yeah.
Not mine.
Yeah.
Yeah, but I think there's definitely room for that type of design to be thought of. The second question, I'm not really sure what the comment is.
Yeah, we had a very low, very few male respondents, and so we couldn't really look at any differences between male and female, kind of stratifying it in that way, because it would just not be statistically stable, because I think we had 2 or 3 male respondents. So yeah, that was really, it was unfortunate, because I think especially because the HPV vaccinate, obviously we know that HPV infection can cause a whole host of different cancers that do affect men. In our context, it's very much geared towards girls and women, and so it would have been interesting to get a more male perspective and see if there was differences between male and female thoughts and feelings around HPV, but unfortunately that was, and I suppose that also just speaks to the fact that probably most primary school teachers are female, and people in that role are female.
Yeah.
So yeah. And then also maybe principals, I think more principals are men. So there's, and we had a very low response rate from principals. So
Yeah. That's very interesting.
That's interesting, because I mean you've picked up now on inherent gender biases within the education system.
Yeah.
Well, congratulations. Thank you.
Thank you.
Thanks, Zee, for that question. So another question I had, so tying in like what Rande said about the feelings about sex education, we know there's parents often are unhappy with contraceptives being available at schools, all of that. In the past, there was a stigma of cervical cancer or HPV only being an issue amongst those with multiple sexual partners. So there's kind of a feeling as in, if my child is not going to have multiple sexual partners, why am I putting these ideas in her head and giving something to prevent? Did you still pick up on that, or are we moving past the stigma?
I think when we were engaging in the community initially, there was definitely a sense that there are parents who do believe if you give your daughter or child the HPV vaccine, then you are encouraging behaviors. But it wasn't, we didn't really pick up on it's a thing of multiple partners, but more that it's almost the parents felt that it would encourage like earlier sexual behaviors in their children if they do allow them to get vaccinated. So that was interesting, but I don't know if you guys had any, but not really the stigma of multiple partners, more that it's enabling behaviors, that sort of thing.
I think as a like separate study, it would be very interesting to look at parents' beliefs. Because I remember discussing like in 4th year when we were designing our original protocol, I remember discussing very much all of those things, like why are parents refusing, or and wanting to look at that, and then eventually ending up with the school staff.
Okay. Very interesting. Then I just wanted to ask about the knowledge questions, right? So I noticed a bit of medical jargon there, and I wondered if you had that because you were talking to teachers and people that you expected to understand that, or if it was something that came from the Korean questionnaire that you adapted, or whether you considered anything around that, because, you know, measuring knowledge, if there's jargon and there might be misunderstanding of the words rather than actual knowledge of the aspects. So I just wondered if you had any thoughts on that.
Yeah, so in developing the questionnaire, we had, so obviously when we were sending it through to HREC, when it came back, that was also something that came up, was the jargon. So in the table, we didn't really put in all the explanations, but on the actual, that will obviously be attached in the appendix. It did have even the word infection, HPV, all of those words that could be considered medical jargon were explained in full and sort of put on the questionnaire. And then as part of, after we did that, we then piloted with educators, so teachers that weren't part of our participant group, and then got feedback from them in terms of, was the language understandable and that sort of thing for people who aren't in the medical field. And also we piloted to people who weren't working as school health representatives, so they had even less exposure to medical terminology. And the feedback that we got was it was easy to understand with our footnotes and explanations, etc.
Okay, great.
Yeah.
Then one more question about relating to the research. So you're all going to be interns in a few months' time. Has this experience, will this change the way you do anything in your clinical practice, or not really? It's fine if it's not really, you can say that. But, you know, is it going to have any impact on your clinical practice in any way? Do you think it's changed the way you would do things as differently to how your colleagues who haven't actually immersed themselves in this particular area would?
I think in a very, like a very low level thing, it's just this exact thing of like the importance of explaining to patients why we do certain things and what the test is that I'm doing, or what, you know, why am I taking your blood? What does this result mean? You know, what is this viral load that you keep telling me the number of? Like, I think that, not just this experience, but in general, that's something that has really become very clear, is that a lot of patients just don't understand what you're doing to them, and why. And this is just like such a really epitomizes that of like, we're telling you all the time that you need to do these things and go for your pap smear. But if you have, why would you, if you have absolutely no idea why you're doing it?
Okay.
I don't know.
Anybody else want to add anything?
It feels a bit ambitious to say, but I think like the one, like if I had to take one learning point from the whole process, it's been to ask more questions. Like I think like that's the one thing that's been consistent through the project, is asking questions, then looking for answers. And I'd like to try and carry that through going into internship, and maybe be a part of more research in the future, but more just ask questions in general and see, is there something that can be done differently? Is this the right thing to begin with, etc.
Great. It's interesting though what you say, Zoe, about wanting to explain, because I remember as a junior doctor going with that mentality and then being told by the nurses that you're taking too long and you're telling them stories. And so it's an important balance to strike, but at the same time, the same patient may come back for multiple issues because that original aspect wasn't explained properly in the first place. So it's a fine balance to be able to strike that engagement and be able to explain things well. So are there any questions about the research? Because I'm going to pivot into the experience, the undergraduate experience. Any other questions? I don't see any hands online. Yes.
I think it's really interesting that you switch to the teachers, because, you know, quite often we expect patients to behave in certain ways. They don't do it, they're bad patients. But it's a real recognition that there's so many gatekeepers that prevent patients from doing what they're supposed to do. There's parents and teachers or somebody else, the health workers. Commend you on that.
And just my own understanding, the school nurse, I was very impressed that there were school nurses. How many schools do they service
All 48.
There's one nurse. The full
They used to have more, but since budget cuts, it's one nurse.
And she is a hero.
She really is.
Okay, and it's really great that you saw that side of it, because otherwise you would sit in your clinics and not know that there's all these other team members that can be drawn on and establish relationships when you work in community. So that's fantastic. So now I want to just pivot to your experience of doing the research as undergrads. So if you could just tell us, I mean, I know that I remember when you were in fourth year, Dean was especially passionate about taking this forward. And it's really great to see how that continued from, we often, as a result of all of you guys doing these, more students are interested now because they can see that it happens. But if you could maybe just describe what made you continue and how that experience has been juggling it, because we know that fifth year is very busy academically and all, but you managed to do that, and any thoughts on that and any suggestions or tips?
I think the biggest tip for doing any kind of research or planning anything is to have a dean.
Definitely.
If you can get one of those, then you're all set. Yeah, I think from my side, I think a big thing was we worked a lot in December of 2023. So at the end of fourth year, I remember working really hard on finishing up our protocol and getting all of that sorted. And then in terms of juggling things, obviously, Dean really was amazing in terms of organizing things and liaising with people. And I think we wouldn't have done anything without him. But in terms of the rest, the writing up, the analysis, everything else, it was actually manageable in terms of just having. I think we all knew that we were in the same boat. We were all working really hard, and we also made a really good thing that we did was we requested to be in the same group. So we were in the same blocks. So we all had EOB at the same time. We all knew that the next 3 weeks is not going to be nothing going to happen. And then, so that was very critical for last year, I think. And just plugging away at it, and obviously having a really great supervisor who kept us accountable and be where are things?
Record turnaround time. It's same day responses of changes to things. And I also think it was really, really wonderful to have undergraduate experience in how rigorous academia can be, and just in terms of, because before we pivoted our protocol, we had obviously already had a questionnaire, and then realizing quite late actually, but the study context for the original questions, although similar, wasn't validated in the context that we were going to use it in. And I think not having been involved in any research, I didn't know the value of that, and the tools that we use and why they have to be used in other contexts in the right way. And then we had to change and sort of find different papers, and that's when we found the Dr. Joe's found the Korean study that we then adapted and piloted and everything. But small things like that I don't think, I mean, obviously the health and context block is wonderful, but I think it's these small things that you only learn when you actually are doing research. So I think that was really wonderful. And then also, there are a lot of hurdles. I mean, CASA, all four of us couldn't go, which we completely understand. But I think there's also a lot of gatekeepers in academia that we didn't know about. The cost to apply to journals if you're self-funded is ridiculously high, and which are not bad. They are. It's difficult, but it's also good to be aware of them, because then you understand the way that research happens and then how it functions. And going forward, when you're a clinician, or whether you do research later, if you're a registrar and you do an MEd, understanding these things, I think, is very valuable. Going forward. So, great exposure.
Very useful feedback. So they say one of our registrars actually said that getting a student group to finish their research like you have is the equivalent to getting a mom in obstetrics to name their child after you. So I just want to give your supervisor, Maria.
Maybe all of your children are.
Brilliant. Do you have any? Want to acknowledge the team, as they said, they've worked on this for 2 years consistently. Weekends, holidays, elective time. I don't think they've shown me the results of their research, but offline, I have been in contact with the school health nurse, and she's actually seeing all the other positive impacts since the students have been consistently engaging with the schools and with the principals over these 2 years, such that some schools that previously didn't give her access for these vaccine campaigns this year are now giving her access, which she believes is because the students have supported her before, during, and after their research at all of her health education interactions with the staff. So I think that's really just a testament to the fact that they, from the beginning, were not setting out to do exploitative type of a research. They wanted to give back. They wanted to support what was already happening and answer questions that organically came out from that context, which is, I guess, the kind of research we try to do as a university. Research that is responsive and that, basically supports the services. So, I just want to commend them, and I look forward to their graduation. And celebrate them properly. But I do want to encourage, if there's other students that's on the call on this meeting, that if you do want to take that step and you do want to do research while you're an undergrad, yes, it is a time commitment. The team that you put together is very important. I don't think they've mentioned that in their Health in Context original group, there were team members that opted out or chose not to proceed. And I think that's also incredibly brave, that at a student level, you're acknowledging what your limits are, you're acknowledging what your interests are. And if you feel that, actually I can't manage additional work, or this isn't really what I'm interested in, to say, actually, I'm going to step back, you guys go ahead. And I think that's also an important conversation for teams to have if they do decide to take something forward. But
Thanks, Maria. And so when I was a fourth year, we used to do the projects, small projects in the public health block. And then later, as a registrar, I actually went back to those same community stakeholders and did an expand project. So there is, like Nsiki suggested, a qualitative component. You said there are still areas that you want to tease out. So maybe you yourselves would be able to, or give it as a suggestion for other researchers to pick up. But really, congratulations. This is fantastic work, and we're so glad you were able to present to us. And we look forward to seeing that publication.
There's another dean, and that's the Dean of Health Sciences.
And you've got quite a lot of online congratulations and claps as well. So please have a look at that.
Thank you.
Thanks.
Great.
Thank you for having us.
Yeah.
Can we take a team photo?
Yes.
Strikes me, you have one publication about your front end. You also have a publication